we have these therapies. We have hydroxyurea, phlebotomy, aspirin, interferon in selected patients. How do we then describe or understand or recognize the patient who has progression of their disease and needs something beyond those? Serge, do you want to handle that?
If we all agree that the goal of therapy is at the level of 5 factors, we have control of red blood cells, white cells, platelets, symptoms, and spleen. This is what we want to achieve. So it's intuitive then to say progression or loss of a control, maybe that's better in some cases, is progressive splenomegaly or symptomatic splenomegaly, symptomatic thrombocytosis, progressive leukocytosis, and need for phlebotomies, which may be frequent and perhaps even symptomatic to a patient. So not eliminating frequent phlebotomies would be one failure of the therapy. So lack of control of red blood cells, platelets, symptoms, spleen, and platelets. Symptoms in particular, we already talked about symptoms. Even with control of the blood cell count, you can have very symptomatic patient. And you need to talk about the person, not about the numbers. I agree that 45% hematocrit control is number one, proven in prospective random study to be a key, but everything else is important as well, and particularly quality of life of the patient. So if you don't have these 5 factors covered very well, you may actually think about changing the therapy. Then you have intolerance to therapy. Ruben has very well described the intolerance to hydroxyurea. Obviously, you would change. And then the last issue is actual event, thromboembolic event or hemorrhagic event, while you are controlling all the factors with, let's say, hydroxyurea. Patient is on hydroxyurea, numbers are good, quality of life is okay. Patient has a pulmonary emboli or has a MI. I would probably consider that a failure, because what you're trying to do is, with the control of the count, is eliminate or decrease the risk of thromboembolism. And if you have it, you probably would consider changing to a next line of therapy. Depends on the degree of difficulty, what kind of event we are talking about. But that's number 7. We have these 5 factors, plus the intolerance. Number 6 and 7 is actual event to consider changing the therapy from front line to second line.
Well, that's, I have trouble with that one, and I want to bring that up for discussion. So a new event, a new thrombotic event occurs, but the patient has no constitutional symptoms, no splenomegaly, and all of their blood counts are well controlled. What data do we have that changing from hydroxyurea to interferon or hydroxyurea to ruxolitinib, our available agents, can actually negate or reduce that risk even further? And let's not forget, it depends on the event. If it's Budd-Chiari, maybe. If it's an MI in somebody with hypercholesterolemia, I'm not so certain.
Yeah, I think it's the clinical setting, right?
The clinical setting
if you have a good alternative explanation, if you have uncontrolled counts in that setting and you don't have a good explanation why somebody had a acute MI out of the blue and or like a DVT was not explained, and I think that could justify changing the treatment. You are right, we don't have solid data for that, but I think that's where your clinical sense is weighs on those things. And
see, I think that's a very important point. To me, if someone has an MI and they have coronary artery disease, my question is, have I done them a disservice by not controlling their counts? And I like to look at the CBC at the time of the event. Because in a way, this is what was done in the Martioli data. They looked at the CBC immediately preceding the thrombotic event. And if there was an abnormality there, then obviously this may have been related to uncontrolled counts. So it's as if it's a failure of a therapeutic INR, because it fluctuates over and then you get a thromb. So I tend to think that perfect control of counts is truly the mainstay of therapy in this case.
I'd say the most common scenario when you really dig into them, as Jamile raises, is that they're really not well controlled when the event occurs. And fundamentally, it's usually because of the issue of tolerance. So I have a lot of patients who come to see me who are kind of controlled on hydroxyurea because they're on their maximum tolerated dose. But even with that, they're needing phlebotomies. Their white count is high. Their platelets are high. So they're not well controlled at all, but they're on hydroxyurea, but it's at really, it just is not tolerated, so it really is ineffectual. And the event is usually in that time that really should just raise to individuals, we really need to change course to achieve that sort of protective level of control.
So what I've heard from you all is that a new thrombotic event in a patient should be a red flag that maybe the disease isn't controlled, and to work to look at that and ameliorate those factors and maybe change therapy if necessary. One thing I'd like to add to your discussion about progression is this phlebotomy issue. Not quite as benign as it's been made out to be over the years, and I think one of the biggest complications of it is iron deficiency. That is the whole goal of it, and iron deficiency can really affect the quality of life of our patients. I think we need to keep that in mind when talking about how we'll just use phlebotomy month after month.